Some of the provocative tests for the vestibular system are listed here in the picture. This is the side-lying test, where the individual has their head turned. It's somewhat like a Dix-Hall-Pike maneuver, where you're trying to get different angles on the semicircular canals that are vertical-horizontal. A new diagnostic tool called the reverse autorotation test has recently been shown to outperform the traditional supine roll test when evaluating horizontal canal BPV. This test elicits nystagmus more reliably and improves accuracy in determining the affected canal. The Dix-Hall-Pike test is as described there. You have the individual sit in the clinical table, turn their head to either the right shoulder or to the left shoulder, and guide them down. Don't let them flop down to have their head dangle lower than the table. This maneuver is really hard to do in older adults. A lot of them have cervical neck arthritis, and it's very difficult to get them to lower their head below the horizontal of the clinic table. Nonetheless, this is the procedure that you need to do for Dix-Hall-Pike maneuver. Some of the other tests that we need to consider are to look for anemia, calcium electrolyte disorders, both vitamin B12 and folate deficiencies, particularly folate in the diabetic patient, as well as thyroid disease. Hypothyroidism is often associated with hearing loss. With vestibular disorders, you might want to consider audiometry. Look at cochlear symptoms, such as tinnitus or asymmetric hearing loss, and differentiate between acoustic neuroma and Meniere's disease. A 2025 study of over 1,100 patients demonstrated that certain audiometric patterns can actually predict vestibular disorders. This means that hearing test profiles may soon play a much larger role in diagnosing dizziness conditions, especially Meniere's disease and BPPV. This is a picture of goggles worn by an older adult, where different provocative images are provided to allow the eyes to track with this procedure called videoanastomography. It is used both for diagnostics for central and peripheral neuropathies associated with vertigo. It is also used for therapy. Whatever procedure that you do for the videoanastomography, it includes cold and warm calorics and cycadic pursuit. Whatever test produces the vertigo, you can use those and replicate them in short recurrent bursts to help the response. Videoanastomography is not available at all clinics. Advanced vestibular diagnostics now include AI-enhanced analysis of nystagmus patterns, as well as expanded use of HIT and VEMP testing. These newer tools improve accuracy in detecting peripheral vestibular abnormalities and may become standard components of vestibular workups. Further diagnostic testing might include an EKG. Look for a prolonged QT interval. People may be on more than one SSRI. Holter and event monitors usually are not too productive but can be considered. Tilt table testing could be used for individuals with a true syncope. If you're looking at acoustic neuromas, tumors, cerebellar disease, neuroimaging with either head CT or MRI, look for things like normal pressure hydrocephalus, which may not contribute directly to dizziness, but may give that sensation of either lightheadedness or wobbliness. The somersault maneuver is another maneuver for habituation for autolymph disease. We now know that lingering dizziness, called residual dizziness, can persist in up to 70% of patients even after successful particle repositioning maneuvers. This non-spinning disequilibrium is especially important in older adults because it significantly increases fall risk and may require additional counseling and therapy. With managing vertigo, we want to look at benign positional vertigo. The Epley maneuver is very similar to the Dix-Hall-Pike maneuver. Occupational therapy or physical therapy can do vestibular rehab, which is the referral of choice. For Meniere's disease, some suggestions are to have salt restriction, to use diuretics, and also to use a vestibular suppressant, such as meclizine. In severe cases, you might consider a referral to the ENT service for decompression therapy. It's an overpressure within the cochlea that needs to be relieved. Stop medications that might be associated with vertigo If they're on chronic aminoglycosides, switching from diuretics to some other type of antihypertensive. Discontinue the nonsteroidal anti-inflammatory medications. Virtual reality enhanced vestibular rehabilitation is emerging as an effective treatment option. VR allows patients to practice balance and movement strategies in controlled environments, improving compensation and speeding recovery from vestibular disorders. Newer repositioning techniques now use real-time tracking and 3D guidance to improve the precision of maneuvers. These advances can help patients with atypical anatomy or recurrent BPPV respond more consistently to treatment. For pre-syncope, treat with hydration, particularly if there's orthostasis. One of the axioms in geriatrics is to avoid dual alpha and beta blockades. If you had somebody on terazosin mini press plus a beta blocker, it's usually not a good combination, particularly in men where the alpha blockade may be used, like Flomax, for prosthetic hypertrophy. It may be better to put them on finasteride as an alternative, because they're both equal in their ability to reduce blockage in benign prostate hypertrophy. Other recommendations are to tell the patient to take it slow. Get up slowly from sitting or lying down. Maybe tap your feet a few times and then get going. Compression stockings are an important adjunctive therapy. Refer them to physical and/or occupational therapy. As a last resort, such as in Shy-Drager syndrome, you may end up using fludrocortisone or midodrine as indicated in terms of postprandial hypotension. The recommendation is to use small meals and to avoid excessive exertion after eating. As we saw by the graph, it can last for a couple of hours after a meal. It's important to keep that time zone in mind. Newer evidence suggests that pyridostigmine can improve standing blood pressure without causing dangerous increases when lying down. Midodrine is now recommended as first-line therapy for patients with Parkinson's disease who have orthostatic hypotension. Combination therapy with pyridostigmine and midodrine has shown a stronger improvement in standing blood pressure than pyridostigmine alone. This may be an option for patients with difficult-to-manage orthostatic symptoms. Here is today's polling question. Which of the following is a recommended first-line treatment for orthostatic hypotension contributing to pre-syncope in older adults? A. Immediate surgery for decompression. B. Hydration and removal of offending medications. C. High-dose antidepressants. Or D. Long-term aminoglycoside antibiotics. The correct answer is B. Hydration and removal of offending medications. For disequilibrium, there are conditions that are associated with ischemia. It could be TIAs, for example. Use antiplatelet therapy. It's also recommended to have postural therapy or gait stability through physical therapy. If there's an acoustic neuroma, a referral to ENT or neurosurgery would be useful. With Parkinson's disease, there's appropriate medications and also rehab therapy. Exercise in Parkinson's disease is better with bicycle therapy than with walking. For some reason, the pedaling is less problematic. Gait and balance, in terms of peripheral neuropathies, is straightforward with either vitamin replacement or treatment of hypothyroidism. With cervical spondylosis, rehab surgery may be indicated, particularly for severe spinal stenosis. It doesn't always help in the long run. To manage other forms of dizziness, we need to consider psychogenic etiologies. Either psychotherapy or antidepressant therapy will deal with the depression. Avoid the SASNRs, the norepinephrine type or class of antidepressants. Those tend to have more side effects on the older adult. Recent analyses show that withdrawal symptoms from antidepressants are less severe than previously believed for most individuals. This is helpful when discussing medication-related dizziness and when planning tapering schedules. For the management of mixed etiologies of dizziness, look for medication issues. Discontinue or give a trial of medications that you consider causing the dizziness. Sometimes both cognitive behavioral training can be an important intervention, as well as medication management. There are different positions in the Epley's maneuver. There's a position sitting up, lying down where you rotate your head. You're in the Sims position here. And then you have head rotations to the left and to the right. This is usually good treatment for benign positional paroxysmal vertigo. There's research on a recent study here from Italy using polyphenol mixtures. They call it Varicoval. In a small study of about 120 patients per control and intervention arm, they found that it reduced subjective sensations of vertigo or dizziness, but there was not objective findings when they did the provocative testing. Interestingly, a study from Europe called the Revert Vertigo Registry found that over 91% of the individuals that had vertigo improved over time. Ginkgo has been used for treatment of vertigo. There isn't a whole lot of evidence to support it, but you may see folks taking that as a non-medical medicinal. New trials show that CGRP-targeting medications, such as galcanezumab and potentially Remage-E-Pant, can significantly reduce dizziness days in patients with vestibular migraine. This represents one of the most important therapeutic advances for this subgroup in years. Recent 2026 reviews highlight residual dizziness as an evolving area of research. Because it is strongly associated with fall risk and reduced quality of life, researchers are pushing for better diagnostic criteria and targeted treatments. Our case study today deals with multifactorial dizziness in an older adult with vestibular hypofunction and comorbid factors. Patient profile. Mr. Robert Thompson, an 81-year-old male retiree living in Montana, presents to the clinic with a 2-month history of recurrent dizziness, described as a mix of spinning sensations, vertigo, triggered by head movements, lightheadedness upon standing, presyncope, and unsteadiness while walking, disequilibrium. He reports vague wooziness at times, impacting his daily activities and increasing fear of falls. Medical history includes hypertension, on metoprolol, and an NSAID for arthritis, type 2 diabetes, mild anxiety, and recent poor sleep. He takes OTC antihistamines for allergies and unreported vitamin supplements. No recent trauma, but he notes occasional tinnitus and asymmetric hearing loss. Clinical evaluation. Vital signs. Seated blood pressure 142/80 mm per mercury, heart rate 70 beats per minute, standing blood pressure 108/68 mm per mercury, heart rate 90 beats per minute, orthostatic hypotension confirmed. Physical exam. Positive Dix-Hallpike on left, rotatory nystagmus and vertigo. Head thrust test suggests vestibular hypofunction, gait unsteady with widened base. No brutes, normal cardiac auscultation, but reduced hand grip strength noted. History. Symptoms worsen with head turns, post-meals, and fatigue, aggravated by rapid position changes. Quality of life affected, avoids driving and outdoor activities in wintry North Dakota weather. Diagnostic testing. Labs show vitamin B12 deficiency, linked to diabetes and sarcopenia per 2024 studies. TSH normal. Audiometry reveals patterns predictive of vestibular disorders, as in 2025 research on greater than 1,100 patients. VNG with AI-enhanced analysis confirms peripheral vestibular abnormality. ECG normal. Polysomnography indicates sleep disturbance contributing to symptoms. No neuroimaging needed absent red flags. Diagnosis. Mixed dizziness, primarily due to benign paroxysmal positional vertigo, BPPV, with vestibular hypofunction, exacerbated by orthostatic hypotension, medication or dehydration related, muscle dysfunction, sarcopenia and frailty from B12 deficiency, and sleep disturbance, psychogenic overlay from anxiety. This multifactorial etiology is common in older adults, 50% of cases, with dizziness increasing fall risk by over 60% if untreated, 2024 Imperial College Study. Management. For vertigo or BPPV, performed Epley maneuver with immediate relief, prescribed home somersault maneuver repetitions. Referred for vestibular rehabilitation therapy, VRT, incorporating VR-enhanced exercises for balance and compensation, emerging as effective per recent advances. For pre-syncope disequilibrium, hydration emphasized, discontinued NSAID and adjusted metoprolol to avoid dual blockade, added compression stockings, slow-rising techniques, and frequent small meals for postprandial hypotension, supplemented vitamin B12 to address deficiency and associated muscle weakness or sarcopenia. 2024 study links to dizziness. Considered pyridostigmine and midodrine combo if persistent, newer evidence for difficult cases. For other factors, sleep hygiene counseling and short-term psychotherapy for anxiety, avoided high-risk antidepressants. Multifactorial intervention included OT and PT for gait training and fall prevention, using bicycle therapy for balance, beneficial in similar cases. Overall, early intervention stress to reduce fall risk, 86% lower with VRT within 3 months, per 2023 and 2025 studies. Patient educated on OTC reporting, 50% underreported. Outcome and follow-up. At 6-week follow-up, symptoms improved 85%, aligning with REVERT Registry's 91% rate. Residual dizziness managed with ongoing VRT and monitoring via CLEAR algorithm, 2025 tool for post-BPPV disequilibrium. No falls, enhanced quality of life with better sleep and strength. This case underscores the complexity of dizziness in older adults, challenging classification but responsive to etiology-focused, interdisciplinary care, including recent advances like AI diagnostics and targeted rehab. In summary, the precise classification of dizziness into the concepts of true vertigo, pre-syncope, disequilibrium, and lightheadedness can be a challenge for the clinician. That's why it's important to do a structured exam and get a good history. Most dizziness will resolve, and it can be habituated. Those are all the reassuring aspects in discussing the problem with the patient. Keep in mind that while you may do a good medication history, half of the patients don't volunteer that they're taking over-the-counter supplementals, or perhaps a spouse, friend, or another family member's medication or supplemental. It's always important to really do a deep dive in the questioning about their medication use. Some of the key physical exams include a mandatory check for orthostatic hypotension and performing different provocative tests, like the Dix-Hall pipe maneuver, as well as observing gait. The fundamental treatment of dizziness needs to focus on the underlying etiology or disorder. That's the end of this presentation. We appreciate your attention and look forward to having you view some of the other presentations that we have on principles of geriatrics. Thank you.